And I just had a nice little conversation with Monica, and I've just asked everyone to um, put where they're from in the chat box so that I can see where everyone's from. Because if anyone needs to find a epilepsy center, we are all about that. Well, welcome, welcome. I want to thank Epilepsy Awareness Expo for inviting our organization, Epilepsy Support Network of Orange County. We're here in Orange County, very close to Brad and Candy, and they're in Irvine, we're in Costa Mesa. And usually when this event is in person, we're the welcome wagon. We're the table in front that is just sprinkled in everything purple, and we have such a fun time. So I'm going to try to make this as fun as possible. I don't think I'll be able to capture the ambiance of the event in person, but we're going to do our best. My topic is seizure recognition and first aid. And this is for you, so if you have questions, put them in the chat. We're going to try to cover as much as possible. And I'm going to talk pretty fast so we can cover as much ground as possible. Please feel free to put your questions in the chat and we'll try to get to all of them. Okay, folks, let's get started. Kathy's closing the door on me. Okay, so who we are. The Epilepsy Support Network of Orange County is a 501c3 nonprofit organization, and we are founded by parents of children with epilepsy who are heartbroken and devastated by the inability to stop their children's seizures and their side effects and cognitive decline. And I know that many of you understand that. And my daughter started having seizures when she was 3.5. And what a long, strange trip it's been. I'm just going to say that much. Our mission is we're committed to building a community of support to improve the lives of those affected by epilepsy through education programs and advocacy. And our vision is a seizure-free community. So how did we begin? Well, we started, again, as a group of parents, and then what we did is we learned as much as possible about epilepsy and decided we need to help others. We've learned a lot. So we started a nonprofit, and we began starting essential programs. And we knew what programs were essential because we were living and suffering with epilepsy every day. So what we heard from our members, and our programs are member driven. Our members tell us what they want and we make those programs happen. And that's just the way it is with our organization. And I think that's why we have been successful. We've been with this organization for 12 years, but our roots are in Orange County for 20 years helping individuals with epilepsy. So through our programs, we do an epilepsy expert series where we invite speakers, much like what Brad's doing today, to come and speak to our parents. When we're in non-COVID times, we meet in person, and we have 10 programs in one location at one time. We serve teen and young adult. We have a Friday Friends Club for children. We have an adult support group. We have an emotional support group with a epilepsy-specific psychologist, and we also have Spanish interpretation. We do community outreach, seizure recognition, and first aid presentations to schools, so staff is ready to deal with your child's specific seizure type. And we do building a healthy brain to presentation to young parents so they know what to look out for in seizures. And we do our epilepsy walk in April every year. And some of these photos, like we have the teens, we have our young kids, we have our walk, we have our community education, seizure recognition and first aid, we have advocacy, and then this is our epilepsy awareness event, which happens this Friday, and it's called Talk to the Doc, where we're going to be bringing doctors on our Zoom to talk to our members. Okay, so we do this presentation for a lot of schools and clubs and organization, and we want people to have a basic understanding of epilepsy and seizures and the effects seizures have on the brain to be able to identify the most common seizure types, identify when seizures begin and end, keep individuals safe during seizures, and know when medical intervention is needed, and be able to respond confidently to seizures. And basically, everything we do is to keep people safe. So let's start with seizures. What is a seizure? Well, a seizure is a brief, abnormal, excessive, or robust discharge of electrical activity in the brain that alters one or more of the following: awareness, sensation, actions, or movements. And epilepsy is one of those conditions that you really can't see many seizures beginning, or sometimes you don't see the seizures because it's electrical activity in the brain, and you have to have an EEG, an electroencephalogram, to be able to measure that activity and know that it's happening. Tonic clonic seizures, also used to be known as grand mal, that's very easy to identify, and you'd be able to point that out and say, that looks like a seizure. But many other seizure types, you wouldn't know unless they're hooked up to an EEG. Epilepsy is a neurological condition where the main symptom is a seizure. 2 or more unprovoked seizures is epilepsy in a very short duration of time. It's primarily a pediatric condition lasting into adulthood, and it affects 1 in 50 children ages newborn to 18. They will be diagnosed with epilepsy. 1 in 100 adults have been or will be diagnosed with epilepsy, and 1 in 26 people will be diagnosed with epilepsy. So it gives you an idea how common it is. It is more common than cerebral palsy, Parkinson's, and multiple sclerosis combined. So if you know 26 people, 1 in those 26 will be diagnosed with epilepsy. And we need to be talking about it more. We need to be advocating about epilepsy more, because the question is, why don't people tell you if they have epilepsy? They need to tell you, they need to talk about it, and especially during this awareness month where you have all of these programs and activities and events like Epilepsy Awareness Expo, because we have to advance forward all together to make great progress for epilepsy. And that's what we're doing right now. There's an urgency to epilepsy, and the urgency is that it can be a fatal condition. About 50,000 people die of seizures or seizure-related causes or accidents each year in the United States. And we need to work together to bring that, that number down. And we're going to talk about how we're going to do that. So just to give you an idea, over 40,000 people die each year from breast cancer, and you see their campaign. They have a wonderful campaign. They're doing good work. They're getting the word out. But with as much attention as breast cancer gets, you would think that it might be higher than epilepsy, and it's not true. I want to put this in perspective for you. 15,000 people die each year from prescription overdoses, and that is a tremendous campaign too, and they do a good job with that. 12,000 people die each year from skin cancer, and 10,000 from drunk driving accidents. So when you look at all of these, epilepsy is more than the highest one, and if you add all the lower ones together, it doesn't add up to what epilepsy takes from us each year. So I'm asking all of you, especially during Epilepsy Awareness Month, talk about epilepsy, share your stories, get the word out so more people will feel comfortable talking about their condition. So let's talk about what's really important about getting seizure control. And getting seizure control is what everyone, that needs to be the primary goal for everyone that has epilepsy, because seizures can damage the brain. It damages brain cells. It can cause brain cell death, and we know that it can cause seizure-related accidents and death, and SUDEP is a huge concern with epilepsy. So let's focus right now on how do you get seizure control. Well, if you get a great diagnosis, then that launches you onto a trajectory to get best possible seizure control. And how do you get a good diagnosis? Well, in the United States and around the world, there are places called epilepsy centers, and they have different levels. And a level 4 epilepsy center is the highest level that an epilepsy center can be. And you want to seek care if you're still struggling with seizures, or if your loved one, your children, your spouse, if they're still having seizures. It's all about getting to a level 4 pediatric or adult epilepsy center, and they even have transition of care centers for young adults. So we want to get to epilepsy centers because there are some very important people at epilepsy centers, epileptologists, okay? And they're the highest trained epilepsy experts. And if you can get a good diagnosis from an epileptologist at a comprehensive epilepsy center where they do all of these diagnostic studies and more, it's hard to keep up with everything they're doing because they're doing such a great job for advancing epilepsy research and care. And like I said, we're located in Orange County, California, which is between Los Angeles and San Diego. And we have a level 4 pediatric epilepsy center. We have a level 4 adult center right down the street. And we have another level 4 epilepsy center for adults in Orange. And we have an emerging epilepsy center at Mission Hospital. And we even have a free clinic for those who don't have, for those adults who don't have epilepsy insurance. And we promote all of these centers because we know it is our members' best chance of getting seizure control. Okay, so we talked about diagnosis and how to get a great diagnosis. Level 4 epilepsy centers, okay? And once you get an accurate diagnosis, and with epilepsy, I know all of you are with me when I say this can take forever. And before we had a pediatric epilepsy center or effective epilepsy centers, our epileptologists were come and go. And now that we have stable epilepsy centers that are thriving, we are making such great progress. But it took 9 doctors to diagnose my daughter, and it was very difficult finding epilepsy centers. So we advocated for all of the epilepsy centers in our area, and we all worked together for the best possible outcomes for patients and our members. So once you get an accurate diagnosis, then what you want to do is pursue the most effective treatment options. And level 4 epilepsy centers are going to know immediately what those are, and you will be able to access all treatment options. And the treatment options that are the most common are medication, surgical evaluation, it would be neurosurgery, and now the surgical implants are making huge progress for treatment options. And of course, diets like the ketogenic diet, low glycemic index, are modified Atkins. And with all of the treatment options available and with the top doctors that are studying your case, that gives you best possible treatment options, which means best possible seizure control. Everyone asks, what are the most common causes of epilepsy? Well, when I first started working in epilepsy, we had this 30% number. If you can do an MRI or a PET scan and you saw an anomaly, a problem with the brain, an injury, cortical dysplasia, maybe it was vascular, that's what you're looking for. But that only covered 30% of causes of epilepsies. And all of us that had children or loved ones with epilepsy, we could see genetic components, and we were talking about genetics way before they were able to get us genetic testing that could show us about the genetic correlation to epilepsy. And now it's about 70% that we know that people with epilepsy, the cause used to be idiopathic, cryptogenic, or theoretical. And now we know that there are many genetic components that also deal with metabolic and mitochondrial issues with epilepsy. And on a presentation I was on this morning, they said there are 400 genes associated that have been identified. I think they're going to identify many more, but over 400 genes identified with the genetic epilepsies. So those are very quickly the most common causes of epilepsy, and that's why genetic testing is a really big deal right now with epilepsy. And ask your doctor about free genetic testing for new cases through a company that provides that. And if you can ask your doctor about that, I'm sure they'll try to get you aligned with that company that provides free genetic testing. Okay, so families, you have power and you have control. If you've gotten to an epilepsy center, if you're seeing an epileptologist, they usually reserve the epileptologist for the more difficult to control refractory epilepsies. So I want to make sure that everyone knows that if the epilepsy centers have epilepsy-specific neurologists, they might be able to get your seizures under control. And if that is the case, that is wonderful. If not, then you may ask for to be advanced to an epileptologist. And you are your child's advocate, so you need to ask for these things. If you feel that you need more attention or someone with more experience to take a look at your loved one with epilepsy. And many epilepsy centers of excellence, they roundtable and they share expertise to give their patients the best possible care. So let's go back to you. What can you do besides giving the medication on time and following the doctor's orders? You need to get to know what the triggers are for your loved one with epilepsy. And here are the most common triggers. For adults, it's missed or late medication, because usually parents don't let their kids miss medication. They're in charge of that, and it works out very, very well. Sleep deprivation, fatigue, and illness, they're very common triggers for seizures. And if you can monitor sleep, there were several sleep presentations telling you exactly how much sleep children need. Infants need 14 to 16 hours. Children need 8 to 10 hours. So if you can go on the Academy of Pediatrics and website and see what the number of hours of sleep for your different ages of your children, young adults, teens, and you may want to add an extra hour because a lot of the epilepsy medications can make people sleepy and they may need extra sleep. So you don't want to have sleep-deprived family members with epilepsy because that could cause a seizure. Fatigue can cause a seizure. Now, illness, flus, colds, illnesses. COVID hasn't been a difficult illness, and this is a surprise because many other things can trigger seizures, but we have not been hearing that from the medical professionals, and we're not hearing it from our 2,000 members. So what is causing breakthrough seizures is when we have a heat wave. We're in Southern California, and we have them every year. So overheating, overexertion, dehydration, those things can cause seizures. So we can monitor this, stay in charge of it, and prevent it. Stress, anxiety, this is huge for adults, and we're seeing it younger and younger with our kids. As young as grade school, where as soon as the academics start pressurizing the children, you can see if you have children with anxiety, and anxiety and depression are very common comorbidities for people with epilepsy. So anxiety and stress can provoke seizures. So that's something else you really want to monitor. You want to make sure that you're alleviating or not adding any anxiety or stress, because if we can limit as much anxiety and stress, do self-care, meditation, plenty of rest, then you can also limit your seizures. Now, if stress and anxiety are getting the best of you and it's causing seizures, then it's probably time to treat that. So you'll need to ask your doctor for a referral, or if they can treat stress and anxiety. And sometimes treating the stress and anxiety can lower your seizures as well, decrease your seizures as well. For women, hormonal changes in menses can cause seizures, and that's usually on the day before the first day of their period and the last day or a day after the last day of their period. And that is called catamenial epilepsies. So if you're tracking seizures and you see that, please bring that to the attention of your doctor, because there are things that can be done, because it's a new day for people with epilepsy, and we have many things that can help with seizure control. If you don't have seizure control, caffeine isn't really going to help too much. So you want to stay away from those energy drinks, from highly caffeinated drinks. If you're drinking coffee every day, you might want to stop that and see if that helps you with seizure control, and talk to your doctor about it. We know that hyperventilation and flashing lights can trigger some seizure types. There are specific types. Drug interactions, including prescription or over-the-counter medications, sometimes they interfere with the processing of the medication. So absolutely talk to your doctor about adding any other medications, especially if you don't have seizure control. And then if you ever have to switch from a brand medication to a generic and you notice that you have breakthrough seizures, please bring that to the attention of your doctor, because you may need to be on brand. Some people are on generic medications and they are completely seizure-free, and that's wonderful. It's less of a headache, but if you have to be on brand medication to stop your seizures and that's what it takes, then if you can work that out with your doctor and your pharmacist. It does take sometimes extra time and effort, but it usually can be done if it's proven that the generic medication is causing breakthroughs. With our adolescent and adult, alcohol, marijuana, recreational drugs can provoke seizures, and marijuana is not a treatment for epilepsy. There's cannabidiol, which is Epidiolex, which is FDA approved. So you don't want to confuse those. You don't want to interchange those. You want to talk to your doctor about that. And alcohol withdrawals can cause seizures, so you always want to be under the care of your doctor. Okay, as we know, seizures cause many problems, and that's why we work so hard about getting seizures under control. First and foremost, seizure control, because they are the most threatening part of the condition of epilepsy, is we're pursuing seizure control. And why? Is it just medical? No, it permeates into all aspects of one's life. We have short-term memory issues with seizures, slow processing, interictal activity. That means the graphic we showed at the beginning, where there's activity, brainwave activity going on that you can't see. If you can only see it with an EEG, then you would ask for another EEG. If you notice any of these symptoms when your child or young adult were doing well and all of a sudden they're back to having these symptoms, then you might want to ask for an EEG to see if there's subclinical activity going. And those are spikes that are happening that you really can't see. Maybe there's no physical manifestation, but you're seeing it in schoolwork and behaviors and attitude, etc. It also may seizures can cause drowsiness, inattention, concentration issues, impulsivity issues, behavioral changes, delayed social development. And we all know that parents want good grades and kids want friends, and they eventually are going to want to get a driver's license. So you need to start very early to get seizure control. So before they're 16, they have a good year or two under their belt of seizure freedom, so everyone feels much safer about that. So I put delayed social development, inability to get a driver's license, because we are advocating for our teens and young adults, and that's what they really want. And so we want to make sure that parents hear that loud and clear. Can epilepsy have a dual diagnosis? Of course, there's epilepsy and autism. 30% of individuals with autism, maybe more severe autism, especially with a nonverbal autism group, they're going to have develop seizures. Cerebral palsy, about 50% of children with CP have seizures, and Down syndrome experiences a certain seizure type as well. So we see epilepsy in other conditions as well. So you want to have your eyes open for those things. Just because you have one diagnosis doesn't mean that you might have another diagnosis. And if you suspect it, talk to your doctors about it, because they need to explore both. If it's epilepsy and autism, they need to explore that and make choices for both conditions. Okay, so there are two main seizure types that we identify, and this is kind of a more simplified version than the epileptologists would teach, but we want to show you that there are two seizure types, focal and generalized. Most seizures last from 30 seconds to 1.5 minutes, and that's a very quick seizure episode unless you're responsible for it. Then it can seem like it takes forever, and what could be a 30-second or 1.5 minute seizure might feel to you that it was 5 minutes or 6 minutes. So you always want to be timing seizures. What's the difference between a focal and a generalized seizure? Well, focal seizures start in one area of the brain, and many times it is the temporal lobe. They seem to be a more hyperexcitable lobe of the brain, and the most easiest to be injured. So temporal lobe is quite common for focal epilepsy, and it starts in one area and then it starts to spread through the brain. Generalized epilepsy is more of a chemical, electrical, and the entire brain experiences a seizure. And at this point, we don't know how it starts or where it starts, but we do know that it travels through both hemispheres of the brain. And that's the difference between a focal point in a small area of one hemisphere versus generalized, which involves both hemispheres of the brain. Now, focal can generalize if it goes on for a while and it starts to become progressive. And many focal epilepsies are progressive, so you want to stop the seizures as soon as you notice them. I tell parents all the time, don't minimize it, don't think it's going to go away on its own. What's happening is the brain is teaching the neurons how to have seizures. So when you hear seizures beget seizures, then the brain can become epileptogenic, so the neurons are becoming hyperexcitable, and you don't want the neurons to get too much experience becoming hyperexcitable, because then what that does is it creates an epileptogenic brain that is hyperexcitable, and it's going to be harder to stop the seizures. Okay, so we have different types of focal seizures, and we have different types of generalized seizures, and we have a lot of syndromes. So when we say, let's leave the diagnostics to the epilepsy centers and the epileptologists, that's the reason why, is because they have to be able to do EEGs and then read the EEGs and then look at the symptoms and say, is this a individual seizure type? Is this part of a syndrome? What syndrome could it be? Let's do genetic testing. Let's find out what we have here and the scope of what is going on. So what I'd like to do now is show you a very benign looking seizure type, and it's called an infantile spasm, and it's one of those seizure types that are often overlooked. It's missed. It is thought to be a a reflex, a startle reflex, because that's what we learn in our, development classes and mommy and me classes. And then you also learn that babies have reflux, but they don't teach you about infantile spasms. And this is about one case in every 2,000 babies. And if it's missed, then they can have very severe effects for the brain. And what it does is it equates to a lot of brain damage, because the window for treating infantile spasms is 4 to 6 weeks. So, but by the time parents realize what it is, it's way beyond 4 to 6 weeks. Then they take another 2 to 3 weeks, maybe longer because it's COVID, to get into the doctors. And the doctor does a referral to a neurologist, pediatric neurologist. But what we're suggesting, because we just received a grant for spreading awareness about infantile spasms, is that if you suspect your baby is having infantile spasms, or you see someone who makes these movements, then they need to go straight to an epilepsy center emergency room and say the words infantile spasms. And this is what infantile spasms look like. That's a spasm. And so it does look like a startle reflex. It could look like reflux. That's a spasm. And how can this perfect looking baby, another spasm, and they do cluster and they happen when they're sleepy or after they've eaten, when they're tired, that's a spasm. And that's a spasm. So although they look very subtle, we want you to be aware of it. We want you to get the word out. We want you to share the information, because these babies, these infants, are waiting for people to notice and then get them to an epilepsy center. And they need to go to an epilepsy center because they need specific, there are only 3 treatments that work, and they need these specific treatments. So if you want to learn more about infantile spasms, please do. Please look it up and follow the steps on infantile spasms. And if you think this is how your child's epilepsy started, you definitely need to bring that to the attention of your doctors. It's a specific seizure type, and it's called infantile spasm while they're infants. And if they're older, they're called epileptic spasms. So definitely take a look at those and educate yourself on infantile spasms. And you can look at the ISAN network, and you'll get much information on infantile spasms. Okay, how am I doing for time? Okay, I want to show you a couple more infantile spasms. Let's
First,
see.
infantile spasms.
I'm going to go to the next one.
These
Let's see if I can go.
typically begin around 6 months to 2 years of age, but can his arms extending in a
I think I have more infantile
first
spasms that I can't move forward. Let's see. Okay. I want to show you this brief. It looks very brief. Watch the grimace on his face. That's an infantile spasm, and it's just beginning to emerge, and you can see it's a little grimace, and that's a little bit stronger. But if you didn't know it was an infantile spasm, what would you think it was? And would you have an urgency attached to it as far as getting this perfect little sweet angel baby, the help that he needs? And how would you go about doing that? And we all need to know how to do that. And all those are infantile spasms. And again, straight to an emergency room that is attached to a pediatric epilepsy center, because there are only 3 treatments that work. Okay, we're going to move forward. Going to look at another infantile spasms, just show you a little bit of an older child so you don't miss them. And that is, his arms went forward and he went backwards, and that's a spasm. And they do cluster. That's another spasm. And another spasm. So you get an idea of what infantile spasms look like, and they need to be treated immediately.
Okay.
You can't wait. You can't wait for doctor's appointments and referrals, etc. You need to act now and go straight to the emergency room. And please do not say my child's doing funny movements or awkward movements. Please use the word infantile spasms. Okay, so seizure recognition. Focal seizures, seizures that start in one part of the brain, may present differently. It's very difficult to be able to identify different seizure types until they're on, a patient is on the EEG, but the types that we want to talk about are focal aware. Used to be called simple partial. When someone is having a seizure, the beginning of a seizure, and they can tell you. They can tell you that they smell a funny smell, taste a funny taste, or that they're feeling a tingling, or something is happening and they can explain it to you. And that is a focal aware seizure. And if they can identify that every time they have a seizure, then they can tell their parents, etc., and you can get the emergency medication ready and you can observe them and respond if necessary. Now, focal impaired awareness is when the seizure is involving more of the brain and it impairs their awareness and they are unaware. And it used to be known as a complex partial seizure. And sometimes when they have a focal impaired awareness, they are unable to talk, they're staring off, they do repetitive non-purposeful movements, starts with a blank stare, clumsy or disoriented movements, usually lasts 1 to 3 minutes, and they may not want to be restrained or directed because the brain is telling them what to do, and they're going to do what the seizure is telling them what to do. So watch this little guy. He's happy, he's demonstrative, he's showing emotions, he's playing, he's interacting with a group. And then what happens? Well, he's having a seizure. He's having a focal impaired because now he is not aware that the preschool teacher and the other student is there. He's picking his clothes, doing non-purposeful movements. He has a neurological look in his eye, and he's doing repetitive lip smacking. And so if you notice this with your child or loved one, you would start timing it immediately. And she's moving him away from the wood and the metal in case this focal seizure expands into both hemispheres and it generalizes and he stiffens up and then falls. So you can see she's doing an excellent job of caretaking. She's patting his back. She's talking to him. Another student's inquiring. She's so calm. And she's just explaining that he's having a seizure and she's taking care of him. So if she were to be timing it, we might be approaching a minute. He's still staring off and picking at his clothing and doing non-purposeful movements. And now he's starting to come out of it because he's looking and he's thinking, where am I? What happened? I was over there. And he's trying to gather his thoughts to try to explain what is happening. Takes a big deep breath to recapture any lost oxygen, and he's going to be very tired afterwards. Now let's see if I can get to the other seizure type. This, every time I use this, well, every new place I use this presentation, sometimes it changes and sometimes it doesn't. Let's see if I can get this to go to the next one. I have
Here's another example of complex partial seizures.
Okay.
Notice how this 4-year-old boy's
So this is focal impaired. He's watching TV and eating. So he's staring and he's chewing. So we have to decide, is he watching TV and just eating? So we call his name, we do a visual test and say, can you hear me? Can you see me? What I would do is jump in front of the TV, and if he doesn't have a little tantrum, then you know he's having a seizure. And as soon as you determine that it's a seizure, then you start timing it and you stay with him, and the doctor will tell you at what point to use emergency medication. And generally speaking, it's usually at 5 minutes, and we're going to talk about emergency medications later. But as we know, and as we've said before, seizures last usually 1.5 minutes. So generally, they're just going to ride through this seizure naturally, and between 30 seconds and 1.5 minutes, and they'll be tired afterwards, and you'll want to let them rest, but also report to the doctor that they've had breakthrough seizures, because we're trying to eliminate and stop and prevent every breakthrough seizure. Okay. First aid for non-convulsive seizures. So that's a focal aware or focal impaired, when they're not aware of their surroundings, the focal impaired. And the really tough thing about epilepsy is epilepsy patients cannot be in charge of themselves when they're having a focal impaired or a tonic-clonic seizure. And they must rely on family members, friends, bystanders to help them. It's a very vulnerable place to be in, and no one really wants that. And again, that's why we're trying to get every seizure under control. But people that spend time with your loved one, schools and after-school clubs and church and maybe where they volunteer or work, they all need to be trained in seizure recognition and first aid to help them through these seizures and to normalize their life, because this is their normal existence. And we need to help them while they're working on seizure control so that they can live as neurotypical a life as possible, because that's what everyone deserves. Okay, so first aid for non-convulsive seizures is, if it's a first-time seizure, you're always going to call 911. If it's a seizure near water or when someone's been swimming, it's 911. If it's a seizure with a pregnant woman, 911. Okay? We're going to look for change in level of consciousness or awareness. We're going to look for that dull affect, blank staring, non-purposeful movements, aimlessness, chewing motions, or lip smacking. And if we have ascertained through calling their name, trying to get their attention, moving their arm a little bit, and trying to physically get their attention, and we decide it's a seizure, then we're going to stay calm and we're going to start timing the seizure. We're not going to restrain unless it's dangerous, unless they're going to walk into the street or walk downstairs or go somewhere where it's going to be hard to supervise. So you can always redirect and kind of point them in the direction if they're walking, and you kind of do that dance for a while until the seizure stops, which again, I'll remind you, it's usually from 30 to 1.5 minutes. And you know your loved one's seizure profile, and you know how long the seizures last. And if they're staying within their profile, then it's all good. If they're coming out of their profile, seizures are lasting longer, having multiple seizures in a row, we're going to talk about that. We're going to speak calmly to the person, and as they return to full consciousness, we're going to help reorient them to prior to the seizure, the situation prior to the seizure, because it's going to take them a while to orient themselves. But if we provide them the information, where they were, what they were doing, etc., then it is very calming, and it's very supporting, and it's very accepting. And we're not going to pressure them to talk, because many times they can't, because speech takes 7 to 9 areas of the brain that all need to sync up together like a computer. So their brain needs to reboot so they can talk and get back to a pre-seizure state. So there's pre-ictal, before the seizure. There's ictal, which is during the seizure, and post-ictal is the time after the seizure that it takes to recover. And so you'll want to notice that time and make sure that the post-ictal times aren't getting longer and longer. We want them to be getting shorter and shorter as the seizures get shorter and shorter. Seizure recognition for generalized seizures. There's absent seizures, and there's generalized tonic-clonic seizures, myoclonic seizures, atonic drop seizures, and many other seizures. But we're going to watch an absent seizure because this is a common seizure type. So tell me when there's a neurological look in the eyes, the head drops a little bit, slack muscle, right there the seizure starts. And we have a neurological look. Let's start counting. 1, 1,000, 2, 1,000, and she's done by about 3 seconds. So this is the difference between an absent seizure and a focal impaired. She looks around and she says, oh, I'm doing my homework. Boom, right back to her homework. She's not exhausted. She's not tired. She's not groggy. And this is a typical absence seizure. And they can happen 20 times a day. They can happen 100 times a day. Usually when you're tired, when you're exhausted, when you're stressed, that's when you're going to have absence seizures. But just because it looks benign, please know that absence seizures are connected with tonic-clonic seizures. And absence seizures that are not controlled can turn into tonic-clonic seizures. So many parents overlook absence seizures and say, don't worry, they're just little ones. Well, you need to get these seizures under control to be completely seizure-free. And you have a 65% chance of being seizure-free and coming off medication if you have your absence under control for 1 or 2 or more years. That's a conversation you have to have with your doctor, because you never take anyone off epilepsy medication without an EEG and your doctor studying the individual patient and making that decision with the family. So you don't want to miss your absence seizure window. Getting seizures under control as soon as possible. They look benign, but they are not benign, and it's what it's doing is it's priming the brain for a tonic-clonic seizure. Okay, many people say, "Oh, absence seizures will go away on their own." I would not bet on that. Okay, myoclonic seizures. You'll see little jerking, almost like electrical jolts, and those are myoclonic seizures. They happen in clusters, and they are part of a syndrome. So you always want to look for those seizures as well and report to your doctor. Now, sleep myoclonus is when you do this little jerking in your sleep. That is normal. It is abnormal when you're doing it when you're awake. So those are myoclonic seizures. One more time, quick seizures. Yes. When you're tired, usually happens between the first hour of waking and the hour before you go to bed during approaching sleep stages. A tonic seizure is also known as a drop seizure, and it looks like all muscles relax, and that's exactly what happens. Just like through a tonic-clonic seizures, all muscles can, tighten up and flex. With atonic or drop seizure, it is a generalized seizure, and the muscles all relax at the same time, and you'll see the head drop, because the head is the heaviest appendage, and it's the heaviest, and so it's going to drop straight to the ground. Many kids with drop seizures do go straight to the ground and have head injuries. So if you see drop seizures, really analyze, because most parents think, oh, they tripped, they're growing into their feet, they're clumsy. We have all these excuses, but it's hard to miss drop seizures because they'll be dropping out of the blue. And if you do see drop seizures, you need to report those to the doctor as well. Okay, generalized tonic-clonic seizures. And as you know, these are all real seizures. So we're going to start with an infant with a generalized tonic-clonic seizure. And little baby, little muscles, little flexing, the tonic flexing of the arms and eyes are open. As you see, they're open and they're blinking. And I think it's between 60 and 70% of people do have their eyes open when they're having a tonic-clonic seizure, which is part of the seizure profile. Okay, so this is an older child having a tonic-clonic seizure in sleep. So many people have tonic-clonic seizures in sleep, and it is very dangerous because you have the pillow, you have the covers, you can roll over and, have loss of oxygen because you may be lying face down on your pillows or blankets or mattress. So nocturnal tonic-clonic seizures are very dangerous, and you definitely want to get to an epilepsy center to get them stopped. They too last anywhere from 30 seconds to a minute and a half. You want to turn the individual on their side, and that helps excess saliva naturally flow out of the mouth so it doesn't pull at the back of their throat. So when they inhale a lot of saliva that can aspirate into their lungs. So you want to turn them on their side, you want to time it You want to get the rescue medication there as soon as possible. And usually, the doctors will say, at 5 minutes, give the rescue medication. Okay? First aid for tonic clonic seizures. Look for loss of consciousness, falling, stiffening, or jerking movements. Stay calm and start timing the seizure. Roll a person on his or her side to prevent aspiration. Breathing in excess saliva that cannot be swallowed during a seizure. Cushion head, remove glasses, loosen tight neckwear. Keep airway clear for natural expulsion of saliva. Make sure hands and legs are not hitting anything. Remove obstacles such as furniture, anything that can cause bodily harm. We're going to move obstacles away. We're going to leave the person where they are unless it's a very dangerous situation. If you're here in California, if the sidewalk is hot or the asphalt is hot, it's 105 degrees out, start tucking things under their skin so they don't get burns, because they can't tell you where they're hurting or what's happening. We have to caretake for them. Do not restrain. Have emergency medication handy, and deliver emergency medication at 5 minutes or when the doctor's emergency seizure plan dictates. And also you can call 911. You also want to check for a medical ID bracelet. If you're somewhere where it's a first-time seizure, you don't know if it's a first-time seizure, you can say, Mom, is this a first-time seizure? Yes, it's a first-time seizure. You call 911 because we don't know the seizure profile. We don't know how long it's going to last. Okay, so we all know about Diastat, emergency medication. Okay, just messed up here. Now I got to go back. Newer medications that are intranasal is Nasolam and Valtoco. So we have Nasolam, which is for ages 12 and up, and Valtoco, which is for ages 6 and up. Much easier to use. The doctors are reporting the same level of efficacy, and socially it's a lot more acceptable than a rectal medication. And we can start normalizing epilepsy emergency medication. So talk to your doctors about this type of medication, especially if you have tweens and older teens. Talk to them about transitioning from the rectal to the intranasal. I wanted to share that with you because so many of our members are very excited about the new intranasal emergency medications. Seizure don'ts. Don't put anything in their mouth. Do not give oral medications during a seizure unless your doctor has okayed it and has taught you how to do it. What we don't want you doing is putting their large Depakote pill in their mouth and hoping that they'll be able to swallow it and stop the seizure. You need emergency medication for that, and please talk to your doctor. Do not restrain. Do not give food or drink until a person is back to their full level of awareness and consciousness. Seizure dues. If a seizure lasts longer than 5 minutes, call 911. Follow his or her seizure plan. The doctors will give you a seizure plan. Do reassure the person and allow him or her to rest after a seizure. Stay with the person until he or she is fully awake and reoriented, because the most dangerous time to have a seizure is right after they have a seizure, because the neurons are highly charged and ready to have another seizure. It's like priming the pump. Visually monitor as individual is at risk for additional seizures. When to call 911. First time seizure, seizure in water, pregnant women having a seizure, convulsive seizure lasting longer than 5 minutes, not regaining consciousness after a seizure. Many people will want to sleep, and you're going to have to, as long as you can hear them snoring and they're breathing, you will have to let them sleep, because it's very hard to wake someone up after they've had that much physical activity. More seizures than usual, or a change in type of seizure or frequency of seizures. Normal breathing does not resume after a seizure. Requested in the seizure plan to call 911 after a seizure. Some seizure plans do that. If there's a dual diagnosis, you have asthma or let's say diabetes, and you're very concerned, the person is medically fragile, then definitely call 911. It's asking a lot for you to know all the intricacies about a dual diagnosis individual. Epilepsy comorbidities. Yes, 57% of people with epilepsy have anxiety, 43% have depression. If we know about it and we can plan for it, we can get kids into social skills group, we can get them very active and socially connected and maintain their friendship. That's very important. People with epilepsy do have suicidal ideation, 13% more than the population. And you can imagine the difficulty of having a seizure, especially if it starts in teen or adolescent years. So you want to keep them connected. You want to be connected to an epilepsy organization that has programs and services and instills self-esteem for young ones, teens, adults with epilepsy. Okay, so I think I still have a couple minutes. Take-home message. Seizures must be stopped as soon as possible. Yes, we can all agree on that. And we don't want to watch any more seizures than we have to. Seizures are harmful to the brain and normal development. Yes, another reason to stop seizures. As you can tell, I'm very passionate about this. Seizures can cause more seizures. Absolutely. The brain becomes epileptogenic and becomes a seizure-producing machine. Independence is severely compromised and commensurate with seizure frequency. So the more seizures, the less independence. And we really want to give everyone as much independence as possible because that feeds into self-esteem, self-worth, all those great things that people need.
Hey, Jana, just to let you know, the session after you is just a video recording. So if you go over, it's no big deal.
Oh,
So
okay.
yeah, you don't have to rush through your presentation.
I'm
Yeah.
going as fast as I can.
Yeah, no problem. You're all good.
Okay. Epilepsy centers are best hope for seizure control. Yes, and we know where they are. And if they're there, they might be in your backyard. They may be a little ways away, but we can help you with finding an epilepsy centers. And Epilepsy Support Network, we're here to help with all of the above. Compassion drives our organization to urgently help children, teens, and adults find relief from seizures. We care because our grief is your grief, and your grief about epilepsy and pain and suffering is exactly what we have experienced. And I believe we're all put on this earth to help one another with difficult situations and alleviate pain and suffering if you don't have to experience it. And if there's an easier way with epilepsy, then we want to help you find that easier way. So our inspiration, we have helped all these kiddos get to seizure freedom. Each of them had their own path, and Ginger, her mom donated to our walks and her daughter started having absent seizures. She knew exactly what it was because my daughter had absent seizures. She called me. We got her to an epilepsy center. She was a tween, and we know that during the tween years, seizures can go from absence to, like we said, tonic, clonic. So time was not on our side, and we advocated for her, got her in. Her first medication worked at an epilepsy center because they knew what they were doing. She was seizure-free in 2 years, and she's off medication, seizure-free. Best case scenario, because we really tailored the doctors and the treatment to her. Mickey was having infantile spasms. We got her to Chalk Epilepsy Center. She needed brain surgery because she had a focal point in her brain, and she had brain surgery on her first birthday, and she is seizure-free. Mason had infantile spasms. Mickey had infantile spasms too, and he is now seizure-free with medication. And Olivia had brain surgery, but she needed a second brain surgery, and that happened at Chalk Children's Hospital, and she is seizure-free too. And one of our school nurses gave us a shout out. We do presentations for her school district each year to keep their kids safe. So you know our inspiration, and now I think I have time for Q&A. Are there any questions? I know we went through that very quickly, but I'd like to ask if there are any questions, if anyone needs help with seizure, with getting to epilepsy centers. I'm going to put our email, info at ESNOC, info at ESNOC.org, and we help individuals find epilepsy centers, and we want to get them, you know, of course, we want to get them seizure free as soon as possible, and that's with epilepsy centers. So if you have any comments, please type them out. If you have any suggestions for our other attendees, we would love that as well. And I think we'll take 1 or 2 more minutes if there are any questions. I'm going to stop my share and go back to the group. I hope this has been helpful. I hope that you've learned something. And also, if you don't have an epilepsy advocacy group in your area, you know, all it takes is for a group of concerned people to start something. And I would highly encourage it, because that's what we did here in Orange County. And we are serving a population of 38,000 people with epilepsy. And we have helped so many individuals get to seizure freedom, and also get to epilepsy centers and help them along the way.
I have a question.
Certainly.
Yeah, I want to know, like, I would say, like, a person has seizures and has the VNS, and I would say, like, is pregnant. When the seizures comes or something, they should use the VNS or call 911.
That's a good question for the doctor, because I want to know if there are case studies about the VNS and pregnancy. So I would definitely ask your doctor about that. You can call or email and ask that question, because I don't know. That's a very you know, specific situation. So I want they may want you to call 911. And I don't know, I don't even know about the emergency medications for that, but definitely ask your doctor.
Thank you.
I'll be asking that question next to one of our catamenial epileptologists. Any other questions before I let you go to the other presentations? Well, thank you everyone for tuning in. I appreciate it. I want to thank Epilepsy Awareness Expo for having us and allowing us to speak and help their guests and attendees. And don't forget to wear your purple and talk about your epilepsy, and please share awareness this month and throughout the entire year. Thank you.